Hello and welcome to the EduTalk series hosted by Biotone EduPartner Program, and massage industry experts. With the growing interest and popularity of the EduTalk series, Biotone continues to support virtual learning and building massage community by connecting you with industry experts who share their knowledge and expertise on topics not only for class discussion, but career success. Tonight's expert is Diana Thompson, a practicing massage therapist with over 35 years experience. She's founder and owner of Hands Heal electronic health records, as well as being a research consultant, educator, and past president of Massage Therapy Foundation. She's received numerous industry awards and is author of Hands Heal, Communication, Documentation, and Insurance Billing for Manual Therapists, and Integrative Pain Management, Massage, Movement, and Mindfulness Based Practices. With over 150 types of headaches, each with a different origin or presentation, not all headaches are created equally. Let's listen and learn as Diana discusses recent research supporting the effectiveness of massage therapy in treating headaches. I'm laughing. She'll review migraines, COVID, cervicogenic, and cluster headaches to help you understand how to incorporate the research findings into your treatment plans, including techniques to benefit outcomes. Plus, she'll share practice homework ideas for treatment success. Thank you for having your sound muted and your video off. I'd like to mention that Diana has presented both an EduTalk and the EduTalk author series in the past, and those can be found on biotone.com under the EduTalk tab. All right, we're ready to go. Thank you, Diana, and I'll see you on the other side.
Great. Hey, thank you so much, Donnell. Thank you, everybody, for being here today. And I am going to share my screen. Donnell? Let's see. There we go. Okay, so today we're talking about complex headache syndromes. This is what I will get through today. I'll mention the research as we go. I didn't put the list of research as a handout, but I do have a list of about 22 articles that I've drawn from. So if you'd like a copy of that, please let me know. And forgive me, I'm just getting over a cold. So Donnell mentioned the types of headaches that we're going to talk about today. There is a set of symptoms. There are very similar amongst that grouping. Then we'll talk about treatment plans, and I'll identify the structures that we're going to work on. So complex headache syndrome is a fairly new name that's put out there specifically for headaches that are not responsive to medication. There are so many headaches that massage is very perfect for, if I dare say. but we can really work with so many different types of headaches and get good results. This is a difficult group to get results from, so you may be frustrated with some of these headaches, but I think you're going to really notice a big difference after today. And that's typically because we're working in the major neck area, the major muscles of the neck. And these are really specific to C1 and 2. There's also a trigeminal nerve component to these headaches, and also the cervical sensory nerves. So they call it a trigeminal cervical sensory and motor nerve complex is another name for complex headache syndrome. Yeah, not so much. So these are also dealing with the systemic inflammatory system. So as Donnell said, the types of headaches that we're going to specifically talk about, I'm going to narrow it to 3 because this is such a short time that we have together, but we're going to talk about cluster headaches, which tend to be the most severe type of headaches. Long COVID headaches. This is a new issue that really, really needs to be addressed. And those you'll find if you've been working with people with long COVID are really horrible headaches. And concussion headaches, another new thing that we're really looking at these days that has been given a lot of attention in the last 5 to 10 years. So similar symptoms amongst all of these are that they're chronic, they're severe, and they're specific to inflammatory conditions and the trigeminal nerve, both motor and sensory. Cluster headaches are odd and very specific in that they tend to happen at the same times every day. So you might wake up with them, you might get another one about 4 o'clock in the afternoon, and then a third one even in the evening, but you would get them at those same times on a regular basis. They can last for weeks, they can last for months at a time, they can last for years at a time, and then they can go away for a year or several months. They're short in duration, even though they're really bad. So maybe 30 minutes, maybe an hour and a half. Remission can last, like I said, months or years. They tend to focus around the eyes or forehead. They're often mistaken by migraines or associated with migraines. The trigeminal nerve, we'll find, really focuses on the eyes, the sinuses, and into the jaw. This is the trigeminal nerve. So you can see a branch. See if you can see my cursor coming up behind the eyes, and one in through the sinuses and down into this sinus. And then you've got one that comes down and into the jaw. So in particular into the mandible. So maxillar area and mandible area. I want to show you that there's the motor root as well as the sensory root. So it can affect all the muscles of the face as well as the nerves of the face. And here's just a nice picture you can see all the behind the eyes, the front of the eyes, down the nose is the ophthalmologic nerve. The maxillary nerve hits all the sinuses, and the mandibular nerve. And if you can imagine all the muscles of your jaw being included in that. There's oftentimes TMJ, or what you think is TMJ, and really it's the mandibular nerve. Long COVID, as we know, long COVID tends to happen more to seniors, but or COVID does. Long COVID does not seem to have that same focus. Pardon me. So while we might have more seniors getting COVID, long COVID tends to be equally distributed across ages, and is found sometimes in more women than men. So far, there's so much we don't know. What's really interesting about long COVID is that it breaches the blood-brain barrier, and actually just with COVID in general. The virus goes right across the blood-brain barrier and accesses all parts of the brain. I'm going to show you some really great images of that in just a second. What I want you to understand about that is that COVID causes a cytokine storm, which is what leads to chronic inflammation. And this chronic inflammation creates a huge uptick in your CGRP peptides, which is what we've been measuring for a very long time in migraines. So those two are intimately related, the CGRPs and the migraines. Long COVID is often combined with tinnitus and vertigo, which are also up in the face. I'm so sorry, you guys. Okay. So this is a complex picture, but it gives you a good idea about how the virus crosses over the blood-brain barrier. Oh, I think my picture got cut off. That's terrible. So we have our glial cells up here. The glial cells are how the brain gets cleaned out. It's kind of like the lymph system of the brain. So they attach onto the nerve endings and kind of suck out all of the waste. So anytime there's energy that's created, anytime we have a brain function of any kind, you're going to have some leftover waste. And it's the glial cells that carry that out. So when the glial cells can't do their job, then you get this backup of cytokines. So I want to show you. Here's a good picture. So these are different types of glial cells. They're so small that we didn't even realize they were in existence until fairly recently. They attach onto the neurons and clean them out. And here's a healthy looking group of glial cells attaching onto neurons. Here we have some very unhealthy glial cells. This is an image of dementia, someone's brain with dementia. It's a very similar thing with long COVID. The nervous system is strongly affected by the COVID virus. And when we get damage done to the glial cells, the neurons cannot get clean. And so we get a lot of gunk in our brain. I don't know if you guys have heard about the research that came out. Gosh, it's probably been 15 years now, where they said sleep is what cleans the brain because sleep increases the flow of the cerebral spinal fluid. And when you've got an increased flow of cerebral spinal fluid, that's what just gives your whole brain a bath. It's like turning the shower on high and washing everything away. With glial cells like this, you could get all the sleep in the world and it won't clean out your nervous system in the same way. Here's some healthy glial cells supporting that blood-brain barrier. So they really assist in backing up that blood-brain barrier so that nothing can get through. But once the glial cells have been damaged, that blood-brain barrier is easier to cross, which also creates a problem for the brain. So you can see how with all this damage to the central nervous system, headaches become a bigger issue. And most of the headaches that happen are the result of a central nervous system dysfunction. Concussion headaches have a little bit different scenario. They're more of a shearing injury in the brain. So when the head bounces back and forth on the ground with a tackle, rugby has a lot of concussion injuries. Football does, any contact sports do. And with repeated shearing injury, you get repeated vascular and glial cell damage. Whiplash or cervicogenic headaches are similar, but not exactly. It would really take having repeat whiplash injuries for it to become a more chronic problem. Not something that's impossible by any means, or a more high-speed injury. And I think I mentioned this, they're also associated with jaw problems, as well as the trigeminal issues. So I want to talk about treatments for today. We're not going to have a huge amount of time to get through them or demonstrate them in any way, but these are just some very basic ideas. That will help you think about and plan for the headache treatments that you're going to do in the future, especially if they're in this upper cervical range. So it's amazing how many research papers really talk about the basic symptoms and reasons for the problems that people have, but they very seldom talk about manual therapy treatments, as we, of course, pretty much all know. So most of the studies that were done were really experimenting with different types of medications, but there were a few that just repeatedly talked about C1, C2. And many talked about C3 as well, but then there was a great study that was done just last year that said, you know, it's really not C3, it is C1 and C2, which are not easy to access. So let's talk about how we can get a hold of those two areas and really open up the mobility and get those muscles to relax. So we'll talk about mobilizing the upper cervicals, getting the inflammation out of there as well as out of the central nervous system, and getting those muscles to relax. So we're going to focus on the suboccipital muscles, which I know you're doing, but a lot of times we're addressing them in a way that isn't really, it's too much. I'm trying to think of a nice way to say this. The suboccipitals in people with this type of headache are way too sensitive. That's probably the number one way that you can identify that they're a part of this syndrome, is that the suboccipitals are so tender. And sometimes they'll tell you, sometimes they'll just scrunch their face up. But that's a great way to identify these headaches. The other area we're going to really look at are the suprahyoid muscles and the deep anterior flexors. And I'm talking deep, longus capitis and coli. So the best way to address the suboccipitals without causing pain is to use eye movements. So you can have your client just look up and look down and look up and look down, and then look up to the corner of the room and down to the opposite corner. So try this yourself. You want to do this without really nodding your head in any way, but just the eye movements. Not that you have to hold yourself super still, because you'll move a tiny bit and then go to the other corner of the room and down to the opposite corner. And then see if you can move your head like a bobblehead after that. Talking about moving your upper cervicals is almost impossible to somebody who hasn't done the eye movements. If we hadn't done that first, you wouldn't be able just to bounce your head from side to side and up and down without moving your whole neck. And we don't want to move from the bottom or the middle of the neck, just the top. So really think about, am I just moving C1 and C2 as I do this with Einstein?
Every moment, who's our now?
Okay. That's homework that you're going to give your clients, is to do the eye movements and then do the bobblehead. I had a client yesterday that I thought I'd try this with. She's got scoliosis, but I noticed how very little range of motion she had in her neck. And I did this with her as well and made a huge difference. Okay, so let's look at the suprahyoid. So these are the muscles underneath the mandible. So we've got the mylohyoid, we've got the little hyglossus. It comes all the way back. You can see it kind of loop underneath that fascial strap and come back. And one thing you can do in addition to working on these muscles underneath the mandible is to include some vocalization. If you can get people to do a nice circle, a nice round O while you're working on these, it'll really help loosen that up. It's important, if you can, to loosen up the attachment on these ones off to the side. So, so is it let's see. I guess it's the digastric. That's the one that goes in the strap. So the digastric goes from the mandible up top all the way back to the mastoid process. So if you can get back at the mastoid process and strum that a little bit, get that to loosen up, then the hyoid will drop down. Because a lot of times it'll turn upwards, almost like it's sticking at the ends underneath the back of your mandible. And if you can get it to drop down in the back, that will make a huge difference in the headache. The stylohyoid, you can see way back here. That one goes to the styloid process. I wouldn't pay much attention to that just because that styloid is so fragile. If you've got an interoral certification, I would work underneath the tongue. You can put one hand under the tongue and one hand up into the suprahyoids and kind of rub it together, and you'll get a nice release that way as well. The deep anterior flexors, the longest capitis and the longest coli, are difficult to get to, but if you just put your fingers in at a curve, you don't want to dive straight in to the neck, but if you go behind the thyroid cartilage and back, so it's almost like you're going in and pushing back with the back of your fingers, and work those a little bit. If you use movement while you're doing that, you can get better access. So I put one hand behind the head and just wiggle that around until I can get in there. And then you can do a nice pin and stretch on it. But we've always thought that they're really hard to access, but I swear, if you just do some little movements with the head, you're going to get right back in there. The lymphatic system is the other place that I highly recommend working. There are lymph nodes behind the head as well as in front. So I always do a Spock move, I call it. So you've got fingers behind the ears as well as fingers in front of the ears, and just drain gently, just drag in there. And that's a great way to get to them. So that, pardon me, that trigeminal nerve is just above and behind the ear, because remember, it comes out behind the ocular area and then feeds down into the sinuses. So it's going to be right back here. Anytime you're doing lymphatic drainage, you want to start first at the clavicle and get this group of lymph nodes or collectors to drain into the lymphatic duct. And then you'll drain distal to proximal. So you push towards the heart, but you move away from the heart in direction. So once you clear this, you come up here, clear this. Oopsie, I went back too far. and then up to the chin. So you can see all of the ones submandibular come back to this group of collectors. So you always want to push towards the ear, underneath the ear. Whereas along this triangle, the sinuses would come down to the chin and then back to under the ear. So the Spock move all comes down to this group of collectors and then back down here when you're all done. So once you open it up in this direction, you can drain everything back down. Remember, with lymph drainage, it's basically skin massage. All of these are just deep to the skin. They're not so much behind the muscles, although in the neck, some of them are behind some of the big ones, but they're pretty exposed. This is your anterior triangle, so they're all right there. So I want to get out of slideshow mode and see if I can show you any of those techniques and answer your questions. Just as a summary, be gentle. These headaches are pretty extreme and they're already in pain and you don't want to cause them more pain. Be goal-oriented. I'm very pro have a treatment plan before you start a massage. Of course, you're going to find things that you didn't know were there or that may lead you into a different direction. But as long as you have an idea of what you want to accomplish. So in case of these headaches, you want to calm the trigeminal neuralgia that's going on. You want to calm the muscles of the C1, C2 area and reduce the inflammation of the cranium and the neck and jaw. So the best way to practice these techniques are to do them on yourself so that you know you're being good and gentle and that you really can access C1 and C2 and just start to do it on your clients after you've practiced on yourself. So thanks for putting up with my stupid cough. Of course, now that I'm done with the slides, I'm not coughing. But let's see if I can answer your questions and show you some techniques.
Well, I haven't seen any chats come in, Diana.
Ah,
Oh, wait, here's one, just as I say that. Helping finding adhesions at C3 like clockwork with headache clients. Also mid-start at occipital. Thank you, my passion subject. And that was Elsa.
hey, Elsa, say that again about what
Help
you
finding adhesions at C3
Oh, got it.
like clockwork with headache clients. And that's a question.
Got it.
Also MLD start at occipital.
I always start at the clavicle. Did I say occipital? Start at the clavicle to open up those collectors.
Yes.
And then move up. Like the sternocleidomastoid is a good landmark, but really they're right in front and right behind. Then clear the mandible. So work backwards behind or underneath the mandible. And then you've got a big watershed beneath the ears. So really open that up and then do your Spock move. See if you can, kind of like that. But you're literally just going around both sides of the ear. So the ear fits right in here. And then just draining down behind the ear. If you can, get up atop of the ear so that you really are draining the trigeminal nerve. Now, draining nerves is a really interesting thing. I try and take a lot of different lymph classes, and there was one whole group that said you have to work a little deeper if it's inside the skull, the structure, or just outside the skull. And another school of thought that said, no, you have to really go lighter. You almost have to, like cranial, imagine that you feel it until you do, fake it till you make it sort of thing. I had to do that when I took cranial classes 25 years ago. But you can actually feel the fluid draining out. The support for the glial system is a completely different set of techniques and challenges. Through the Upledger Institute, they've got some brain 1 and 2. I don't know if there's a brain 3 yet, but fascinating work with the glial system. So it very much addresses that part of our brain and central nervous system. So that's what I would recommend from a continuing ed standpoint, because you can actually address the glial system. For this level of class, we're just going to talk about getting the fluid external from the skull, but through the trigeminal nerve, because it's behind, you can get to it behind the ear and get that to drain down into the lymphatic duct.
Now, at the beginning, you mentioned inflammation.
Mm-hmm.
Now, how does inflammation play a part with the fluids and the headache?
Yeah, interesting, huh? With concussion in particular, I think that's a really easy way to talk about it. The brain gets thrown around inside the skull. So the shearing that happens, there was a good story, is when a woman was taking a 7-layer cake to work. And she had it on the seat next to her. You know, it was in a box, but the box wasn't as tall as the cake. It was like a 7-layer cake. She's driving to work. She gets in a car accident. All the frosting ended up either on the side of the box or on the dash and windshield. The 7 cake layers were perfectly stacked on top of each other. So our brain is made up of different types of structures and the fluid that's in there. Our head is not like woodpeckers, for example, where their brain is so tight inside their skull that there's no damage when they're pounding their beak into the tree. Their beak is also below the brain. Whereas with us, it just sloshes back and forth in a whiplash injury or a concussion injury. And so the shearing that happens there damages all the tissue, the connections within the brain, but also the most fragile tissue in there are the glial cells. So those glial cells, when the matrix gets disturbed and sheared, the glial cells get broken. The external part of the cranium, same thing. Blood vessels get broken. And so the lymph system is not able to process the waste because of it. When the waste builds up and there's nowhere for it to go, that's when confusion sets in. Like when you don't sleep for a couple days in a row. You can't really think straight. You feel like your brain is swimming in mud, and all of that happens. Well, with concussion injuries, it's like that all the time. They're just always confused and swimming in mud.
Okay. Elsa had another question.
Please.
Thoughts, and I don't know if I'll pronounce all words correctly, but thoughts on C3 adhesions. And then is it
Oh, yeah.
how do you pronounce the next word, Diana? Meningeal?
Meningeal?
Oh, okay. Meningeal. She's
Yeah.
asking those questions. Thoughts on C3 adhesions and meningeal.
So C3 adhesion. So are you talking specifically about the longest coli in front? And I asked that because the research was very specific to C1 and C2 being problematic with this group of headaches, and not so much C3. C3 is going to be a problem with a lot of headaches and down. But the ones that we're really ignoring, that we shouldn't be ignoring, are C1 and C2. So you feel it at the transverse ligaments. Okay. Posterior, then you're saying, is that right? Or the side? Are you talking about the sides of the, oh, right, transverse processes. So scalenes, maybe. Are you talking ligaments in particular?
Let me unmute Elsa so
Yeah, Elsa.
she can ask the questions directly.
Hello.
Hey, how's it
Hello,
going?
Elsa.
I'm sorry. I was trying to do the best that I could.
You're doing great.
Thank you. So almost to everyone with headache clients, I feel on the, if you imagine C3 at the transverse process and a tiny bit posteriorly, I don't know that what it is for sure. That's why I've never gotten an answer that I went, okay, yeah. Like the closest I got was that it was maybe a meningeal connection, but I feel something and I don't know what it is.
I think rather than naming it, I would find what works best to treat it. And for me, when I get into transverse processes, then I just find a way to move it. So I'm just going to move that head around until I find the gap and can get in there and do some friction on it. Because those joint spaces are so tight, especially when the muscles have adhesions like you talked about, or are just short in general. Those joint spaces shorten up. So just get some movement in there and find a way to get in there, and then just kind of bounce it around as you're working with it to get that space to loosen up. But I'm not sure if naming it exactly, because there's so many small structures in there, soft tissue structures, different layers of fascia, that sometimes I don't care where I am as long as I'm getting a result.
If you could see me, I'm nodding my head. And so thank you very, very much.
Yeah. Yeah.
Thank you,
Yeah.
Elsa, for your question. We still have another minute or two for additional questions or comments, if anyone would like to contribute, while we have Diana here in person. You know, I don't get headaches that often, so I can't really speak from experience, but as a therapist, if I walked in, I might not even think to mention I had a headache.
Oh, you would.
Oh, okay.
With these headaches, I get cluster headaches, which is something that I forgot to mention. For many, many years, they thought it was only men that got cluster headaches, which is ridiculous, right? Kind of drives me nuts. But they're finding more and more that women get cluster headaches. And the last paper I read was that women may get cluster headaches more than men. Who cares, really? I mean, it's más o menos on
Right.
that. But talk hydration and headaches. Yes, absolutely. I think what I've read recently about hydration, which I thought was really interesting. Pardon me, is that it's more important to hydrate before the massage, which I thought was really like a new idea for me. And so I don't know what you're thinking about that, but try it. I have been trying it myself. So hand somebody a glass of water when they walk in. Tell them to drink more water before they come in. That it really helps lubricate things so that you can get more done in the moment.
Okay, I don't.
So I don't know if your name is Glenda or Glenn or GL something. More as a cause than as a treatment for bonking. Anybody who's ever bonked knows what kind of headache that is.
What's
so
bonk?
Absolutely. Oh, like when you're exercising and you get dehydrated. It happened for me mountain biking. We were out for hours. It was hot and sunny, and you're so in the moment, you forget to drink. And then all of a sudden, you can hardly move. You're so dehydrated. And the headache comes on. So absolutely, dehydration can cause headaches. Different type of headache. Less of a central nervous system issue other than just not having enough liquid to clean out your system and your brain. But
well, that's a good tip on the hydration prior to a massage session.
Yeah.
Are there any last minute questions or comments for Diana? And if any come in, Diana, we'll get to that.
Great.
I wanted to mention the upcoming Edu Talks. And we have April 4th with Kelly Lene on Stay Relevant in an Ever-Changing Consumer Market. On April 18th, we'll have Stephanie Lynn Hall, Feng Shui Benefits for Sleep Health, Wellness, and Productivity. And then in May 9th, we'll have Fred Stallman, How Craniosacral Therapy Benefits the PTSD Client. And I'd like to mention later in the year, we will have another talk with another presenter on craniosacral therapy and concussion. So definitely watch your in basket for invitations to the upcoming Edu Talks. And tomorrow, again, you'll receive a follow-up email with the recording for tonight's presentation, with Diana and a worksheet that she has included, as well as her contact information and links to her previous Edu Talks and author series. Thank you very much, Diana. Is there anything in closing that you'd like to add?
It looks like a few people want the research list, so I'll get that to you too. And you can pass that out with the other handout.
Okay, I'll email that out as an attachment tomorrow.
Great.
And I was thinking of offering herbal tea to clients when they arrive. Now I'm definitely going to.
Yeah, great. Which is what I was drinking throughout, but to no avail. Sorry,
Well,
guys.
thank you for pushing
Yeah.
through good information
Good.
and a lot for therapists to take into consideration. And I like the idea of working on yourself.
Yeah.
Yeah, to just get the right feel for it. So thank you very much. Thank you everyone for joining us. Join us again. And watch your in basket for not only the follow-up, but also future invitations. Also, some of my emails with attachments go to spam. So be sure to check your spam folder as well. All right. Thank you so much, everyone.
Yeah.
Join us again and be safe. Take care.
Bye-bye.
Get over your cold, Diana.
Thank
Okay,
you.
bye-bye.